our second panel today. I'm also a Ghanaian immigrant to the US, so I just wanted to say that I appreciated all the thoughts from the first panel on the roles and responsibilities of the African diaspora. So our second panel today the speakers on our panel are going to enlighten us about where Ethiopia stands with respect to several infectious diseases and some of the challenges to future progress. Nellie Bristol and Randall Reves are lead authors on 2 CSIS reports that are being launched today. Shannon Hader is joining us from CDC, and Bernard Nalen from the President's Malaria Initiative. And I'll tell you a little bit more about them before they speak, but thank you all for being here. So as we already touched on in the first panel, Ethiopia has been praised by development professionals for making progress in addressing basic healthcare needs. And as Richard talked about, one of the ways it's done this is by increasing access through training a group of mostly female health extension workers to deliver a basic package of 16 services at community health outposts in the countryside. These health extension workers are drawn from the communities they serve and undergo 1 year of training. And so relevant to infectious diseases, their services include immunizations, prevention and control for malaria, TB, and HIV, and education on hygiene and sanitation. So as we talked again about earlier, the commitment by the Ethiopian government and by international donors to addressing health needs has actually led to some impressive results. Deaths from the major communicable diseases, HIV, AIDS, malaria, and TB, are all on a downward trend. HIV prevalence is currently about 1%, down from 5% in 2001. And there hasn't been an indigenous case of polio since 2001 as well. Cases of severe malaria illness are down about 60% in the last decade. And TB mortality and morbidity has also been cut in half since 1990. And yet, many, many challenges remain, and our panelists today are going to expand upon those challenges. US health assistance has also played a significant role, both financially and technically, in saving and extending the lives of millions of Ethiopian citizens, particularly through disease-specific programs that we're going to get into today, such as polio eradication, bilateral TB programs, the President's Emergency Plan for AIDS Relief, or PEPFAR, and the President's Malaria Initiative, or PMI. Today's panelists are going to focus on how the US government has worked with the Ethiopian government and programs to address infectious diseases, and we'll talk about some recommendations for future US activities. Each panelist is going to speak for a few minutes, and then we'll go into Q&A. So again, I'm only going to give you their brief bio because their full bios are in your packet. Our first speaker, Nellie Bristol, is a senior fellow with the CSIS Global Health Policy Center, and she heads our center's work on polio eradication. She's going to be talking about her new report on polio legacy planning in Ethiopia.
Good morning. Thank you, Audrey. As Audrey mentioned, I take the lead on our global polio eradication work at CSIS, and in particular, over the last several years, we've been focusing on polio legacy planning. Now, what, you might ask, is polio legacy planning? The world has been working on eradicating polio for more than 25 years, and the US government has been a staunch supporter of that effort and is a top country donor globally. Polio eradication has created an intense international pressure to find and identify every case of polio and immunize every child. It has resulted in an extensive collection of public health resources that are now largely concentrated in about a dozen countries around the world that tend to have the weakest immunization systems. Assets developed through polio eradication include laboratories, social mobilization networks, partnerships, advocacy and fundraising, disease surveillance capacity, immunization personnel, and innovations for reaching remote and underserved populations. And many of these assets also address diseases other than polio in some areas. Polio legacy planning is a move to ensure that needed and worthy assets are continued and/or repurposed to other health activities after polio is eradicated. The Global Polio Eradication Initiative, which is a collection of national governments, civil society, academics, led on the global level by WHO, UNICEF, CDC, Rotary International, and the Bill and Melinda Gates Foundation. The GPEI envisions polio legacy planning as being led by the countries themselves, prioritizing folding into country health systems the necessary polio functions, including immunization, surveillance, and laboratories, but also assuring that the knowledge and lessons learned are transferred as well as other worthy infrastructure and capacities. There's an increasing urgency for polio legacy planning as the number of polio cases continues to drop. Only 2 countries remain polio endemic, Afghanistan and Pakistan. Polio funding supports immunization staff, surveillance, and surveillance that could create health system gaps as polio funding drops. The Global Health Policy Center has been looking at the issue for the last several years with a particular focus on the U.S. role in polio, the U.S. government's role in polio legacy planning. How should policymakers and USAID and CDC, the two agencies involved in global polio eradication, ensure that the USG's more than $2 billion investment in global polio eradication over the course of the effort results in long-term public health gains beyond polio eradication? As part of this work, my colleague Chris Millard and I traveled to Ethiopia in October to look at Ethiopia is one of the GPEI focus countries and is also a country that's important to U.S. strategic and humanitarian interests. As Audrey mentioned, Ethiopian leaders have made great strides in improving health indicators, especially for children, but they have a hard time reaching border and pastoralist areas where infrastructure and personnel is lacking. The U.S. is not the largest polio donor in Ethiopia, and it has a relatively small contribution of about $3 million annually, but that money is focused in areas that have the weakest health services. CDC devotes $300,000 for immunization staff. USAID contributes $1 million to WHO for disease surveillance, immunization strengthening, and vaccination campaigns, and another $2 million to the Core Group Polio Project, which is a consortium of US-based but locally staffed NGOs that work at the community level with disadvantaged populations in the border regions, and they work on polio as well as other health issues. US-funded polio assets supplement government services helping to improve immunization for polio and other diseases, and then the help is needed. While Ethiopia saw its last case of indigenous poliovirus in 2001, it has been subject to repeated outbreaks through disease reimportation from its neighbors. In addition, it struggles with other vaccine-preventable diseases, in particular measles, and had the largest number of measles cases in Africa in 2014. Without polio program funding, some important assets could be lost, including WHO surveillance officers, core group supervisors, and who can ensure that vaccinations are being administered correctly, community-based surveillance initiatives, and cross-border coordination to help address disease importation. Polio assets address the health needs of both the Ethiopian and the US governments. Ensuring quality health services reach all of its citizens is a top priority of the Ethiopian government. In addition, improving child health is a long-time US global health goal, while disease surveillance and immunization system improvements contribute to global health security. While polio-funded assets serve both governments, transition planning will be challenging. The Ethiopian government needs to take the lead, involve donors and international organizations and other stakeholders. The staff in the country critical to the effort has other pressing issues and lack the time and technical capacities for the process. So how can the US help? USAID and CDC should catalog polio assets and discuss their contributions to issues beyond polio, look at physical assets, but also lessons learned and innovations for reaching remote populations. With the Ethiopian government in the lead, determine which assets should be continued, which the government can take on itself, and negotiate with donors and other stakeholders for additional support. In particular, the transition plan should look at continuing monitoring and supervision roles of core group and WHO. Polio eradication has created a valuable set of public health assets that should be continued and expanded. They contribute to the health goals of both the Ethiopian government and the U.S. The U.S. should take an active role in planning and implementing a polio transition plan in Ethiopia and elsewhere, and look for ways to continue and expand on important public health gains facilitated by polio program funding.
Thank you, Nellie. Our second speaker, Dr. Randall Reves, is an infectious disease specialist and leader of the Stop TB USA partnership. Randall.
Thank you for the opportunity to talk to you today. I've often begun discussions with what we in clinical medicine call a case presentation. I'd like to tell you a story about two families to begin this talk. So the first begins with the story of a young man named Z, who was a high school senior, intelligent, athletic, popular, who ended up spending 2 months of his senior year isolated due to infectious tuberculosis. I didn't actually take care of this young man, but he presented his story at a national TV meeting back in last June to about 400 people. There was a delay in diagnosis. His physician just couldn't imagine that this healthy young man could have tuberculosis, despite the fact that he'd been adopted from Ethiopia 8 years earlier. During the public health investigation, it was determined that 50 fellow students were infected by TB during this period of time. And the health departments typically will try to maintain complete confidentiality in these situations. The news media hears about it. They write about someone, and they don't specify whether it was a student, a teacher, or a staff person who had TB. This young man's cover was blown by his middle school brother, who announced in his middle school, "Oh, that's my brother that has TB." So as a result of this, the story was out, and he ended up engaging with the local health department to reach out to his friends, his teammates, his classmates, and encourage them to complete treatment for latent TB infection so that they wouldn't get tuberculosis. And they had over a 90% completion rate and didn't have the expected 2 to 5 TB cases the next year. So really, I think a very successful outcome in that respect. He came to a meeting in Denver just last week and again spoke to a crowd of over 400 and told a story that we hadn't actually heard before about how, as an 8-year-old boy in Ethiopia, a single mom living with a grandmother, his mother was struggling to continue to work because she needed to support the family, and she also needed to collect money so she could go and get a medical examination to find out why her cough and her weight loss wouldn't go away. Eventually, she was diagnosed with TB and started on treatment. And this young man was encouraging her to take treatment, assisting her to get back and forth to the clinic. But unfortunately, she died of tuberculosis in spite of treatment. And then his grandmother suggested that he might consider adoption since he was only living with her. And he, I don't know how much choice he had in this, but he said, I accepted that. And he ended up moving to Kansas community and joined a family there who had lost a son in an automobile accident. So his explanation to the meeting last week is, I guess that worked out for both families. So these stories really just provide a basis for understanding and interpreting the TB statistics that are in the report, and then we can discuss now. Based upon estimates from the WHO 2015 report, Ethiopia, with a population of 1 million people, had an estimated 200,000 individuals who had a new onset of active tuberculosis. Ethiopia is 10th among the 22 high-burden countries in the world, and these are the countries that account for 80% of the global TB cases. Of these 200,000 cases, 119,000, almost 120,000, were actually detected and reported. So that means 60% of the cases were detected to the National TB and Leprosy Program. We were amazed at the impressive treatment outcomes that the Ethiopian National TB Program has produced with both the combination of their resources and the support of international donors, including the United States, USAID, and CDC. We found this staff to be highly motivated, intelligent, and really committed to their activities. Notable outcomes include 89% successful treatment outcome with drug-susceptible TB. In addition, they are detecting perhaps 25% or approaching 50% of the multi-drug resistant TB cases in Ethiopia. And looking at the cases diagnosed in 2012, and you have to remember here, you can't look at 2014 because the treatment for multi-drug resistant TB is meant to go on for 2 years. A really brutal treatment that ends up causing hearing loss in 15 to 30% of the patients, sometimes psychosis and severe depression, liver injury, and other complications. So the cohort started on treatment in 2012 had a 83% treatment successful outcome, so clearly demonstrating a commitment to TB treatment. In fact, Ethiopia met all of the 2015 targets set in 1990 by the WHO for reducing the incidence of TB and achieving a 50% reduction in both the prevalence of TB and mortality. Really amazing outcomes. Of the 22 high-burden countries, Ethiopia was one of only 9 who achieved all 3 of those goals, and only 2 of the 9 in the African region, including Uganda. This previous strategy was based on identifying individuals who have TB symptoms and getting sputum collected for microscopic examination for acid-fast bacilli. And that's accomplished a lot, but it only picks up 50% of the individuals who have culture-positive TB. And so as a result, many of the patients treated in the Ethiopian National TB Program are based on a clinical diagnosis. The patient comes in, they're sick, they get sputum collected, the smears are negative, the doctor still thinks they have TB, and eventually they decide we're going to go ahead and treat even though we can't confirm the diagnosis because this really is a case of tuberculosis. Although most of the patients diagnosed and treated in the National TB and Leprosy Program have a successful outcome, Z's mother is one of perhaps 5%. So it's still a deadly disease even in treatment when treatment is successfully completed. So in addition, I want to get back to this issue of the 40%. So about 80,000 Ethiopians who are estimated to have TB in which it's never detected. What happens to them? We think that contributes largely to the estimated 32,000 deaths each year due to tuberculosis in Ethiopia. I would point out that although HIV is important, it accounts for less than 10% of the TB cases in Ethiopia now, and only 5,500 deaths. So the great majority of these deaths are not in HIV-infected individuals. They're in populations who are not infected. The WHO and the Stop TB Partnership, recognizing that the TB decline has slowed and is now going down at only 1.5% a year, released a new NTB strategy just a few months ago. And the goals here are not to try to achieve a 70% case detection rate and 80% treatment completion, but to achieve a 90% detection of cases and 90% successful completion. So these are really ambitious goals and would hope to achieve dramatic reductions in the burden of tuberculosis. Based upon our findings and our assessment and the commitment of the Ethiopian government to meet interim goals, we believe that Ethiopia has the potential to achieve these targets. The major limitation is that the current total funding for TB is $44 million a year, 9% from domestic sources and $35 million from donors. Again, the global fund and the U.S. government are the major contributors. This leaves an estimated funding gap of $38 million based on a budget requirement of $82 million. I would point out that this is really a small number. It sounds big, but the HIV expenditure in Ethiopia is $300 million a year, and that for malaria is $200 million a year. As described in our recommendations, we conclude that successfully detecting and treating 90% of Ethiopians in this new strategy is going to require more funding. Clearly, if they're struggling to achieve these good treatment outcomes with the current 60% case detection, pushing that up to 90% is going to require more funding from both the Ethiopian government as well as from government and international donors. The United States has both a humanitarian and a health interest in working to end TB globally and in Ethiopia. Ethiopian-born patients, such as the high school student in Kansas, accounted for about 140 of the TB cases reported in the U.S. in 2014. Our recommendations are listed in the short document that you have. I dropped on the floor. So for the U.S. government, clearly making it a priority to increase U.S. and multilateral resources available to the Ethiopian government for TB control. I mean, we think this is a critical need because TB is really underfunded globally and underfunded in Ethiopia. They should ensure that careful monitoring of PEPFAR's ongoing transition does not create any adverse consequences for TB control in Europe. And number three, this is a critical one. The reason we have so much problems with treating multi-drug resistant TB today is a technological one. We are using drugs that should have been thrown away. And it's a brutal regimen. I think we'd have to describe it as an unacceptable regimen and yet unavoidable. There are some new drugs that are coming into study now, but the research funding for that is really minuscule compared to what we've seen for HIV/AIDS, and we really need to have the equivalent of a approach used for the atomic bomb. We really need to rapidly accelerate research in order to address this global problem. For the government of Ethiopia, we'd encourage them to explore all domestic and international funding sources. One additional item, we note that they have developed this field epidemiology and training program fostered by the CDC, and they have a very active group. And we would encourage them to look at using that training to train their health staff in the health department staff to pursue epidemiologic evaluation of multi-drug resistant TB, because this is really an ongoing threat in Ethiopia, and why not have the staff in the health departments learn these skills and epidemiology of this condition. They really need to accelerate efforts to close multiple funding gaps. I know there's a lot of discussion earlier about whether the government was really willing to talk about the truth and outcomes. I must say that we were impressed with the National TB and Leprosy annual bulletin. And it described they still have some gaps in ensuring that patients can receive a complete drug supply, gaps in diagnosis, gaps in follow-up. So they clearly recognize that they have some issues that they need to address. So I think there's a real commitment to improve the situation in TB control and elimination in Ethiopia. Thank you very much.
Thank you, Randall. Our next speaker, Dr. Shannon Hader, is the director of the Division of Global HIV and TB at the CDC. Dr. Hader has an extensive background in domestic and international HIV and AIDS and emphasizes accountability, scale, and impact for sustainable responses. Dr. Hader?
Sure, thank you. Good morning. Of course, I didn't start coughing until I put on a mic. Somehow there's a response there. It's really my pleasure to be here to get to talk to you today about work that CDC's done over the years in Ethiopia and with Ethiopia in support of the Ethiopian health response. A little bit abashed to be talking about, we have one of our previous CDC Ethiopia directors, Dr. Tom Kenyon, who will be on the next panel in his new role. So I'm sure he'll add some details as we go along. I think to talk a little bit, we have a broad-based support and relationship between CDC and Ethiopia on health. And I'll talk a little bit about PEPFAR and the HIV and TB work, which has really formed a large amount of our investment in our platform, but also touch on how that relates to new activities in global health security and also our excitement to help support CDC Africa. So I think first, for PEPFAR overall, and this is across all U.S. government agencies, not just CDC, since 2004, through the President's Emergency Plan, the U.S. government has committed nearly $2.4 billion between 2004 and 2015 within Ethiopia as the largest bilateral donor to the Ethiopian health sector. That's very meaningful, and that has yielded a lot of results. Even by the end of 2014, PEPFAR was supporting over 350,000 men, women, and children on life-saving ARV treatment. And when the final 2015 numbers come in, that's going to be over 390,000, close to 400,000 people. And along the way, PEPFAR has done that in a way that has built the health system and resiliency, I think, are in support of the ministry's building of their health system. And that includes more than 35,000 healthcare workers that have been trained in the country since 2009 alone. And there's a breadth and a scale to our supported activities and impact there. Ethiopia has seen a 90% decline in HIV incidents or new infections since 2003. There are integrated mental health services and investments in gender-based violence services that are part of the PEPFAR program. And there have been large efforts and successes in engaging people living with HIV in the ARV services themselves through adherence support, patient tracking, facilitating linkages, and trying to make sure that there's a healthy continuum of services that help people lead healthy and productive lives.
Currently in Ethiopia, wow, that's so strange. Currently in Ethiopia, PEPFAR is aligning its investments to the highest prevalence, highest burden sites and regions, and activities that will continue to save the most lives, prevent the most new HIV infections, and accelerate the country's progress towards achieving control of the HIV epidemic. Some highlights about what CDC specifically has been investing in and what we're continue to focus on going forward. I think number one, we have been very committed to working to transition our PEPFAR support for comprehensive HIV activities to local implementing partners. So at the beginning of the emergency response, we relied heavily on international partners. In the case of Ethiopia, so this included Columbia University, University of Washington, Johns Hopkins University, University of California, San Diego. And since the beginning, there's been a huge building and resiliency of the local infrastructure and responsibility for HIV/AIDS. And we have now transitioned all of our support to Government of Ethiopia entities, primarily 7 regional health bureaus and the Uniformed Services of Ethiopia. And those major transitions of the programs were completed in 2014. We continue to support the regional health bureaus and our partners to deliver services and to scale up the quality and the reach of those services. CDC is also focused on helping support programs that are designed to reach difficult-to-reach populations, such as commercial sex workers, and expanding the use of innovative approaches such as provider-initiated counseling and testing, index case testing, mobile and home-based testing, and ways to reach people who haven't been reached yet. We're also focused as we move forward in helping ensure that our investments and our supports really follow the geography of where the epidemic's at now, and at the same time continue to help scale up ARV services for greater reach in those areas, and help the government to expand viral load monitoring to make sure that the treatment is effective and virus is suppressed in the person in replacement of what used to be CD4 monitoring alone. And in that note, we're very excited and supportive of the fact that the Ministry of Health has recently agreed in Ethiopia to adopt the WHO Test and Start New Guidelines, which is essentially treatment for all, reducing limits to when people start on treatment in recognition of the more recent research data that shows that people's health is actually better and sustained better if they start treatment as soon as they're diagnosed and don't wait for their immune system to be damaged. So that is an exciting opportunity that we're looking to help support the country of Ethiopia on. In terms of TB, and to build a little bit on Dr. Reves, I think most of our support has really been through the HIV-TB sphere, through the PEPFAR program, which, as mentioned, is only really 10% of the active case epidemics. That said, we tried to invest our times in platforms that should help overall, and I think we're very excited when Ethiopia achieved all of its Millennium Development Goals, including those on TB. And in the realm of HIV and TB, there have been really marked recent improvements that the government has achieved, getting up to 92% of their notified TB cases tested for HIV to identify those who might have special needs, and nearly 60% of those who are also HIV positive started rapidly on HIV treatment. Now, we want to get to 100% on that, but that's a vast improvement and very good trajectory. Our work most recently has been really focused in the TB/HIV realm on pediatric TB, case finding, laboratory systems development, and technical support. And we do think that the laboratory systems development and technical support have broad-based impacts across the TB continuum. Right now, we support implementation of TB/HIV integrated activities at close to 1,000 health facilities in Ethiopia. And our lab support spans from supporting the development of TB culture facilities to quality assessment and EQA services, to the expansion of Gene Expert for diagnosing resistant or more difficult to diagnose HIV, and really supporting the National TB Reference Laboratory to be capacitated to do XDR TB diagnosis as well. I think Dr. Reves has made a good case that there's been tremendous progress on TB, but we're not done yet. There's a lot left to do, and this is something that we would like to see a real global commitment across the world of making higher impact in this disease that has just been hanging on for way too many decades and centuries. So, but in addition to that, I think, and most recently highlighted in the global health security arena is, these longstanding relationships, these development of partnerships with the ministry, the field epidemiology training programs, the relationships built through polio eradication. Ethiopia has also become a very important partner with CDC in our global health security agenda, which recognizes we need to help support response to disease abroad to help be safe here at home. And through our global health security agenda, we're helping to work with Ethiopia for their own ability to prevent, detect, and respond to outbreaks and other public health threats as they happen. Elements of that support include working with the National Laboratory System, workforce development, development of an emergency operations center, and technical assistance around the 5 priority zoonotic diseases that are worrisome for health security. And in many cases, we're able to build off of and leverage both the platforms and relationships that were initially created under the PEPFAR program. And I think finally, although not Ethiopia specific, we at CDC really laud the formation and the mission of the new African CDC, which will have a footprint in Addis and is an ongoing platform for member states to share knowledge, exchange lessons learned, and build capacity, and provide technical assistance and collaboration to each other. So we look forward to seeing how that rolls out and are very happy to be a partner in watching that really expand.
Thank you so much. Finally, Dr. Bernard Dallin is the Deputy Coordinator of the President's Malaria Initiative. He has a long career in malaria prevention and control, including work in Kenya, work at the World Health Organization, and at the Global Fund to fight AIDS, TB, and malaria.
Thanks, and again, thanks for the opportunity to be part of this panel. Ethiopia, well, first of all, those who aren't that familiar with the President's Malaria Initiative, just quickly, it was launched by President Bush in 2007, has been expanded under President Obama to the point that we're now involved in 19 high-burden countries in Africa, as well as a regional program in the Mekong focused on combating artemisinin resistance, which has emerged in that region. Ethiopia was actually one of the first countries named for support. It's interesting, Ethiopia's different in many ways than the other countries we work in Africa, just from an epidemiologic focus. The entire country is not malaria prone. The highlands, there's very little malaria transmission or no malaria transmission above a certain altitude, around 2,000 meters. So the central highlands, even though you may see malaria there, it's acquired somewhere else, and people are maybe seen in hospitals and the capital and other areas, but there's no malaria transmission there. However, there's other parts of the country where malaria is highly seasonal and epidemic prone. Historically, Ethiopia, and as I see we have a professor I just met from Howard University who's one of the former malaria program managers in Ethiopia. Historically, Ethiopia would have epidemics every 5 to 8 years, resulting in thousands of deaths within a very short period of time. And lastly, there are other parts of the country which are more like the rest of sub-Saharan Africa, where you have ongoing transmission through large parts of the year. So it's just different epidemiologic zones in the country. Secondly, in most of Africa where we work, we deal almost solely with Plasmodium falciparum, which is the species that kills you. In Ethiopia, in addition to Plasmodium falciparum, they have the other major malaria species, Plasmodium vivax, which makes you feel like you're going to die, but most people don't want to die from that. So it's interesting, and also it's a relapsing species. So there's some other challenges in Ethiopia when we're dealing with 2 species as opposed to just one as we are in the rest of sub-Saharan Africa. And lastly, in most of Ethiopia, people have not, there's not any significant background level of acquired immunity. Most of you are aware in other high burden areas of Africa, if children survive their first few bouts of malaria, they develop fairly good immunity. And even though they may be infected later, they're not at any big risk for severe disease and deaths. In Ethiopia, that's not true. Adults, most adults have no real level of acquired immunity and are at risk for dying. So we don't talk in Ethiopia about this being primarily a disease of children less than 5. It's a disease throughout the entire population. So again, quite different what we're dealing with in Ethiopia. About 65% of the country is malarious, and that involves about 60% of the population. PMI, when we first went in, we focused primarily on Oromia region, which is the most malarious part of the country when it comes to the population at risk. So a lot of our efforts focused on this area where up to 75% of the malaria cases actually occur. But in addition to that, we put quite a bit of resources into helping to build up some of the national systems and actually working with PEPFAR and some of the other programs, for example, around national laboratory strengthening, the whole issue of training around integrated case management of febrile illness. One of the great things that's happened in Ethiopia, which has already been referred to, was the development of the health extension worker system. And malaria, I don't want to say as opposed to HIV and TB, but malaria is a great fit with that system because malaria occurs primarily in rural areas. It affects the poorest of the poor, frequently beyond the extent of the sort of bricks and mortars of the healthcare system. And the nice thing is, with rapid diagnostic tests, which are now widely available, and also with drugs which are inexpensive, and it's a 3-day treatment. It's not a 2-year treatment, fortunately. It's a great fit with that system. About 60% of the malaria cases in Ethiopia that are now being diagnosed are actually done through these health extension workers. As you're aware, the great majority of these 39 health extension workers are women who are assigned to these peripheral health posts in very remote areas. So the PMI since 2007, our total resources that have gone into supporting the malaria control efforts is around $330 million. We're about $40 million this year. And in addition to that, we partner very closely with the Global Fund to fight AIDS, TB, and malaria. The recent grant to Ethiopia for this 3-year period is $150 million over 3 years. So some pretty significant resources. Fortunately, there's been some pretty remarkable leadership. We were somewhat fortunate that the previous minister, Tedros, actually had his PhD in malaria and had an interest in expanding the health sector in general, but knew a lot about malaria and knew what needed to happen to make that move forward. And that's continued under the present minister and the National Malaria Control Program. The results have been pretty remarkable. And I should say most of these results have really occurred in the last 5 or 6 years with a scale up of vector control through long-lasting insecticidal nets, indoor residual spraying, and like I said, the rollout of case management to a very peripheral level, sort of working with this extension of the health system through health extension workers to be able to provide diagnosis and treatment in a timely fashion where it's most needed, which is in these rural areas. It's a great fit with this community platform that's been developed. Audrey's already referred to the fact that severe malaria cases have dropped by 62% since 2010. Outpatient visits due to malaria have dropped by half. The latest complete data that's been put together shows that there were only 112 deaths due to malaria in health facilities in Ethiopia. And that's Ethiopia. Malaria is no longer one of the top causes of deaths in health facilities in Ethiopia, so that's a tremendous success. However, going forward, those are somewhat fragile gains. Again, malaria can come back with a vengeance if people lose focus and take their foot off the gas. There are some issues related to emerging insecticide resistance to the class of insecticides, the only class which presently we have available on the insecticide-treated nets. I mentioned the emergence of artemisinin resistance. All the countries in Africa, including Ethiopia, use artemisinin-based combination therapies. So we're working with the ministry and also with some of the academic partners in Ethiopia to be able to monitor that. Fortunately, there's no evidence anywhere in Africa yet of artemisinin resistance, but that's an important issue which could certainly result in a big reversal of gains if that happens. And then lastly, the success of malaria is really going to depend on the sustainability and the success of this community-based platform, which the government has rolled out with a lot of funding from, Minister Tedros used disease-specific funding from HIV, malaria, and other programs to actually support that rollout. And we need to understand going forward how well that's going to work, because certainly it's crucial for malaria that be a successful component going forward. Thanks.
Great. Thank you so much. Thank you to all of our speakers for some fascinating talks and telling us about the range of infectious diseases and some of the progress that we've made with U.S. investments. I'm going to start off the Q&A session with a couple of questions to the panelists, and then we'll start calling on the audience. So I'll start with Nellie. You talked a bit about how Ethiopia is sort of in the early stages of beginning its polio transition planning. Are there other countries that could serve as a model for some best practices?
Yeah, the one that is most talked about is India, which is a bit of an anomaly because it's wealthier than a lot of the other countries that are looking at this issue. But there was a WHO country representative who really pushed it kind of early on a few years ago, and the government was very receptive. And so they've been able to move some immunization staff to places to bolster up routine immunization in places where it was lacking, and use microplans that they use for polio to keep track of children and make sure they're coming in. It's a different structure because instead of the immunizers going to the houses, the children and the parents have to come to a fixed site. So they're going out and they're figuring out who needs what vaccines and trying to get them to come in. So social mobilization workers from polio are working on creating interest in immunization and educating people. And we actually are traveling to India, hopefully at the end of March, with a delegation to look at this more carefully. But I'd written a report about this in 2014 about kind of the early stages of India moving along.
Great. Thanks, Nellie. And then Randall, you talked a bit about some of the funding gaps that exist for improving TB control. What are some of the priorities for if we were able to increase that funding? Is it primarily diagnostic kits, new diagnostic tools, or are there other priorities as well?
Well, it's one of those things that's I think it's not possible to say which one, because the health extension worker program, we were really quite impressed. There's a nice picture of one of the clinics on one of the report that Richard Downey put together. So here's a clinic with no electricity, no actual purified water system, 2 young women who are able to, with the technologic tools, diagnose malaria in the clinic, provide treatment. They do birth control implants in the clinic. What they can do for TB detection is to inquire in the community, who has these symptoms? And then perhaps they can collect a sputum and send it off, where it'll get examined by a smear, which is about 50% sensitive. They can refer them out, when that doesn't happen. They really lack the kind of tools that would allow that system to really provide services. Now I just heard recently that the company that makes the Gene Expert now has a battery-operated unit, so no longer reliant upon electrical supply. So you can imagine, with that sort of tool out in those clinics, they could actually come almost as close as a culture, which is more sensitive than a smear, in diagnosing someone with TB and whether it's rifampin resistant. It wouldn't eliminate the need for culture, so the country still needs to accelerate the production of the opening of new laboratories that provide culture confirmation, other drug susceptibility testing results. But it would be a huge step forward there. And of course, the other problem is even our standard regimen, which we approved in this country in 1994, is a weak regimen. So we rely a lot on directly observed therapy to prevent acquired drug resistance. You don't have that problem with HIV therapy to that extent. Single pills once a day, no side effects to speak of, and patients are able to get excellent response rates that last for a year or two. And that's the sort of technological breakthrough we need with TB.
Great, thank you so much. And Shannon, you told us about the prior PEPFAR transition in 2014, where PEPFAR really focused on working more with local implementing partners. As some of you are probably aware, PEPFAR is undergoing a new transition right now. Can you maybe talk a little bit about how that's playing out in Ethiopia?
Sure, absolutely. I think we are at a new time in the sort of global HIV response, and that's been led in many ways and championed by UNAIDS and with the Sustainable Development Goals. So Ethiopia, like many countries, has signed on to the Sustainable Development Goals, which really goal is to end HIV as a public health threat going forward with the milestones. And what does that mean? It means one of the strategies being adopted to try to do that is both save lives now and decrease transmission. And one approach to doing that is what we call the 90-90-90 strategy. 90% of those who are infected with HIV know they're infected. 90% of those are on life-saving HIV treatment, and 90% of those are virologically suppressed, meaning the virus is not measurable in their blood and transmission is very, very low, and by most indications they will be deriving the immunologic health benefits of not having that virus replicating. So what does that mean for Ethiopia? Ethiopia was one of the first partners in the PEPFAR program. It was one of the original focus countries. And like most of the countries at the beginning of the PEPFAR program, we worked collaboratively with the data that was known, which in many cases was a national average. And it was a time in the epidemic where in many countries, folks who had been gotten very sick with HIV and had no access to treatment would go home to their rural areas to die. You know, we had hospice all over the place. We had, you know, people will remember the photos of the coffin industries and the deaths spread in many of these countries. And so in Ethiopia, it was really a champion of the beginning PEPFAR program, and we're able to sort of take a broad platform to building what this response could look like and supporting a very broad, you know, trying to hit as many places at once to catch people who are in need of treatment. Fast forward 12 years later, the world's in a very different place, and I think more particularly one of the successes is we have more data at more granularity than we've ever had before. And the epidemic has changed. As people are healthier, they are living and working in different places than just going home maybe to their original homes to live out their last days and be taken care of. And that's a wonderful thing. And what does that look like for Ethiopia? A large country, high population, relatively low prevalence rates across the country, and we know now is not equal across the geography of the country. So just like Bernie wouldn't be doing his malaria programs in the highlands where there's no malaria, we need to really, in this time of budget constriction, help to make sure that the PEPFAR investments in Ethiopia and other places are going where the highest burden, most people who don't have access yet, are left to be served. But that's a little bit of a nuanced transition, I think, because it might mean that in some places those community health workers have been testing for HIV, but they haven't been finding anyone who's positive. And with imperfect tests, you might actually be more likely, if there's no HIV in the community, to find false positives than true positives. So it's not a hold harmless just to do the same things we've been doing for a long time if we know more about the disease and the technologies and where it's at. And so we've been working as PEPFAR and as CDC together with the government to really say, okay, how do we heat map? How do we look at the data we have now? How do we continue to collect more data and help intensify the services in the areas where the most untreated people are left to be found? and how do we streamline, because we're not in a wide open budget environment like it felt like at the beginning of PEPFAR, to make the services as efficient as possible and go as long as possible.
Thanks very much. And Bernard, you talked a bit about some of the progress that PMI has made in really improving malaria control in Ethiopia. One of the issues that our team heard about, ongoing challenges, is issues with drug stockouts, drug shortages. Does PMI have a role in working with programs to improve the supply chain?
Yes. First of all, obviously PMI's progress is only, it's the country's progress, and we work closely, as I mentioned. We're not the major funder always in the countries where we are. It's actually the Global Fund. And some of the issues with commodities, so overall about 40% of our resources go into commodities, and the rest goes into the systems issues. Like I mentioned, we work very closely with other U.S. government health programs like the Maternal Child Health Program of USAID and also PEPFAR around supply chain management and around surveillance systems, et cetera, et cetera. Well, obviously, if you don't have commodities, then supply chain management becomes an issue. And some of the issues with commodities, we actually have an emergency stock of ACTs we've set up, because we've seen this in many countries where sometimes because of glitches in global fund procurement systems, because let's face it, we're the two major purchasers of malaria commodities. There may be a glitch for whatever reason in the global fund system, so it does result in a stock out. If you look at our malaria operational plans, you can see in there that we pay a lot of attention to what the global fund is doing. An example, for example, in Ethiopia, even though we do buy, Ethiopia needs about 26 million bed nets. This year we'll be purchasing around 5 million. The rest of those are purchased by the Global Fund, but frequently the Global Fund doesn't have money to actually distribute the bed nets in their grants. So a lot of our resources then will go into those sorts of issues. So drug stockouts, it's not just drug stockouts. The challenge at the moment in Ethiopia, because I mentioned, is actually making sure the drugs are going to where the malaria is. Because in the old days, through the essential drug kits in most countries, it wasn't very nuanced. There wasn't the sort of data Shannon's referring to that we need. So in most countries, through the essential drug kits, they just send out the same number of anti-malarial drugs as part of these kits. And I lived in Western Kenya for quite a few years, and not surprisingly, there were huge drug stockouts because there was a lot of malaria there. But the same amount of drugs were going to other parts of the country where there was no malaria. So we're working very closely around this whole issue of making sure that these areas that actually need a constant supply of drugs, they actually have those. And diagnostics. I think that's the other success in Ethiopia. Ethiopia has been able, it's one of the first countries in Africa to actually scale up these rapid diagnostic tests, which was a huge step forward, because previously diagnosis for malaria required a microscope, required electricity, or you did have microscopes which you could use, sun, but in most areas it was still, and that was a huge limiting factor. So a lot of febrile illnesses being treated for malaria, we didn't actually know if it was malaria. Whereas now, Ethiopia essentially has all these cases we're talking about now, it's 100% confirmed reporting through rapid diagnostic tests, which is a huge change in malaria. And having that information, and at a very local level through these health extension workers, and being able to look at that, we are working very closely with the government, the supply chain management systems, and also with our Global Fund colleagues to try to make sure that stockouts don't occur.
Okay, thank you so much. Now we'll take questions from the audience. As with the previous panel, we'll take a couple of questions and then let our panelists respond. Start in the back there.
Lawrence Freeman from ER Magazine on Africa. My question is on the DDT. My understanding was DDT was the most effective means of curbing malaria. It was cut back after this, it seems to be an anti-scientific analysis from Silent Spring and other environmentalists. And now some African countries are using it again, I think South Africa and others. Are we now applying, reasserting the scientific value of DDT? Is it in the works? Is it effective? Is it still banned? If you could give me an update, I appreciate it.
Well, first of all, DDT was never banned for indoor residual spraying. There's actually one of the few international health treaties was the POPs Treaty. And there was, even though DDT was supposed to be phased out, there was a rider in that to allow for ongoing use of DDT for human health purposes through indoor residual spraying. The fact is that the amount of insecticides that go onto walls through indoor first of all, there's evidence of some pretty remarkable benefit, and there's no evidence of negative impact through DDT. The challenge with and Ethiopia had a very robust IRS program with DDT, which remains the least expensive and previously one of the most effective. Ethiopia had a huge reliance on DDT. In PMI, in all the countries we support, we've actually tried to build up IRS capacity. In many countries we're using DDT. DDT is now being abandoned, not because of any sort of a restriction. It's just based on the fact that there's now widespread vector resistance to DDT. So it's not the best insecticide to use for indoor residual spraying. So we moved on to other classes, and that's been a challenge because some of the new classes there's like 14 insecticides which WHO has approved for use in indoor residual spraying. I mentioned that pyrethroids are the only class of insecticides on LLINs, so we don't want to use those for IRS because pressure might result in further emergence of pyrethroid resistance. So we're using other classes, organophosphates. There's some new products coming out, which happen to be a lot more expensive, and as opposed to in Ethiopia, where previously we could do one round of spraying with DDT because it lasted. In some of these areas, we're now having to do, so it's becoming much more costly. We haven't talked a lot about these public-private partnerships, but there's something called the Innovative Vector Control Consortium, which is out of Liverpool. It involves some funding from the US government, Gates Foundation and others, to try to bring some of these new products for human health, new insecticides for human health online, and also to help shape the market so they're not that expensive. So to answer your question, if and when the vectors can be killed by DDT again, we would be prepared to bring that back, but that's why we do this insecticide resistance monitoring.
Okay, let's take a couple more questions.
Peter Small from Stony Brook and CSIS fellow. Question for Shannon and Randall. It's very disturbing to hear there are more than 10,000 MDR cases in a grossly underfunded program. They're going to have to make some very, very difficult decisions about prevention and treatment. I'm just wondering what your advice would be to the people on the ground about how they make that trade-off between treating those who have MDR and preventing future cases.
Any more questions? One on this side.
Erin Fry-Sosny from PATH. Thank you all for these great discussions about some of the vertical programs that are happening. I'm wondering if you can talk a little bit about how the interagency works at the country level, realizing these programs are affecting many of the same communities and families. And similarly, how some of the lessons that are learned coming out of the PEPFAR transition pivot could potentially be applied to the polio legacy planning, and what sort of discussions are taking place within the US government to share those lessons. Thank you.
Okay, let's take one more.
Thank you. I'm Hailu Zalalo from USAID Health Finance and Governance Project at Abt Associates. It's a wonderful session. I like the title, specifically the sustainability issue. But the scope of the session is not as broad as I would expect. Like the system-related issues would have been good if they were raised. And financing is also a huge aspect of sustainability. In Ethiopia, in 2010, we had a national health account. 50% of financing for health is coming from donors. So financing is an important aspect, and specifically for these big international initiatives like maybe polio, not that much in terms of scope, but malaria, HIV, TB. For Ethiopia, this is huge. So from the panel, in your plan for sustainability and transition, how are you looking at financing transition as well? How do you think financing will be maintained for sustaining Ethiopia's public health outcomes, especially given that the challenges will be even increasing? The health outcomes was more on prevention areas, which was much easier and less expensive using the health extension program. But some of the issues, it needs higher level treatment, like some of the maternal health issues and others. So how do you see financing and also the broader system strengthening aspect when you think about transition?
Great, thank you. You want to start with Nellie and go down?
Well, I guess just in terms of financing, the Richard's report covered that a little bit. We didn't focus on that a whole lot, but he looked some at the universal health coverage program that Ethiopia is putting together. Yeah, in terms of the interagency in the U.S., I know that for polio legacy planning, the State Department is involved as well as USA and CDC, and they're all trying to figure out what the U.S. government's approach should be to this, whether it should just be done at the country level or whether the U.S. should have some sort of an overarching approach to the issue. And we also are looking at that as well, and we'll have some thoughts about that later in the year. But I know that there are conversations going on, and it is a big, complex issue because the GPEI operates largely at the global level, but then you've got individual donors and there are international organizations that probably could be involved and need to come up with their own plan, and then you've got the country level. So it's vast and it's complicated, and there are a lot of conversations going on now that hopefully will bring some sort of transition planning available to countries.
Great. Thoughts on MDR-TB and sustainability financing?
Yeah, I guess your question was, whether we should focus on preventing MDR-TB or treating the ones that are there. And I think there's not an answer to that question, because if you look globally, there are estimated to be 450,000 new MDR-TB cases globally. And in the end run, after you look at misdetection, failure to start treatment, poor treatment outcomes, about 10% of those individuals actually get a cure. That means 90% continue to have TB for several years before they die, transmitting MDR-TB in their families and their communities. And so that's the problem. The estimates for MDR-TB cases in Ethiopia among the notified cases is about 1,300. They're detecting, half of those maybe now. But if you consider the undetected cases, there's probably over 2,000. And unless we get those diagnosed and treated, they're going to infect more family members, more transmission in the community. The problem with the treatment is the PET study showed that about 9% of people treated for MDR-TB end up failing during treatment and then have XDR-TB. So we need a much better regimen than we currently have. But we need to diagnose people and stop transmission. The other issue of producing it is the lack of drug susceptibility results. So about 10% of the cases in Ethiopia are already resistant to INH, which is one step away from MDR-TB. But they're getting the standard regimen for the last 4 months of INH and rifampin alone, which we know will produce MDR-TB at some frequency. We don't know how high that is, but it's unacceptably high. So we really need a whole change in how we're approaching this problem. I don't know if that answers your question.
Any additional thoughts?
Ditto. I think it's really important to just reflect on the fact that when we first were in the earlier days of recognizing global MDR and XDR, frankly, I think it's just too expensive, it's just too hard, had a whole voice. And there was, I think, a delay in the global response saying that, it's not too complicated or impossible, it just can't be to deal with this in poor nations. And we had that equivalent in the HIV world, right? We had the, you can never have ART treatment in the developing country. You can't give treatment to poor people. It's just too expensive. And we've seen transformation over time in that, right? And I think You know, you highlighted, isn't it a wonderful era for HIV where we have combination pills where you might take 1 pill a day or 2 pills a day that are very effective, a little bit more forgiving on adherence than they were originally, very tolerated. We wouldn't be at 15 million people globally on treatment on our way to 28 million if we were with the drugs we had in 1995. And so, you know, that's a little bit I think is very important for the MDR and overall TB response world to not see these as opposites, you know, as opposed to a continuum. Yes, we have to redouble our effort at basic TB control to prevent the emergence of more and more resistance. That also means we need to refine where we're detecting resistance. We have to identify MDR more quickly so it's not being transmitted earlier. We have to use some of the new tools that now exist. We don't have many new tools in TB, so the ones we have to bring the most out of, like expert diagnosis, and not just get the technology out there, but make sure it's transforming the whole continuum from diagnosis to results to treatment. So a little bit of a cheerleader aspect, but I think my pitch is we have to do better. It can't be an opposition of non-resistant versus resistant TB. And we do need both back to basics and innovation to get to the next level of control.
Great. Let's take a few more questions.
Hi, my name is Yishtala. We have a small business company, INT Biotechnologies. I was traveling to Ethiopia last October and to visit the diagnostic laboratories and institutions. And one of the problem I have seen that is there is no laboratory equipment maintenance or trained laboratory technicians for diagnostic. And what we have, even big laboratories, they lack accessibility for reagents and those things. And we have a meeting at Addis Ababa University, and after our meeting, we have produced a report which give the challenges about laboratory equipment maintenance and services. Probably I'll share that with you when I meet you later on if I get a chance. And how can, I'm glad you are next phases to capacitate diagnostic laboratories so that they can do clinical diagnostic, and for example, for drug resistance TB, there is no, I mean, molecular diagnostic is very, it's not well accustomed in Ethiopia. The reagent is not available. Unless you do molecular diagnostic, it's to be difficult to identify drug resistance TB and other drug resistance infectious parasite. So I think this is your next phase. I think if I discuss this with you personally, it would be great. And this is my concern, the lack of capacity for diagnostic.
Okay, great. Diagnostic challenges. Next door, right next door.
Hello, y'all. My name is Hermela Haile. I'm actually an MPH epidemiology student at GW. So I don't know if you guys have enough time, but I actually have 2 questions. My first one's on surveillance systems. I actually was in Ethiopia in December and January doing a study on uterine ruptures. One of the huge barriers I had was with the healthcare information systems. The charts were all over the place. In one chart, I would find 4 different cases. And when it comes to surveillance, I wanted to know what type of barriers you guys have and how we can strengthen surveillance, particularly with TB, cervical cancer, and other infectious diseases. My second question is about displaced populations, particularly in the Afar region. While I was in Ethiopia, there was a lot of talk about how we're having a hard time reaching the Afar region and other pastoralist communities. And now that these are communities that are going to be hardest hit with the drought, they're going to be more vulnerable for infectious diseases. So I wanted to see what type of strategies we have in preventing epidemics and reaching these populations and getting them back into care so we don't have a situation like Haiti and cholera and other types of infectious diseases. Thank you.
Let's take one more.
Thank you very much, CSIS. I think I've learned more lessons than I have read many books just in very few minutes. I would like to compliment this assembly of people. Please, the first malaria, 1956, United States began the malaria control project in Ethiopia. It was before WHO even. And WHO came on that. That's USAID. It has invested in a lot. Me, I am the graduate of USAID. I got 2 degrees just by being in public health, sent to Michigan, to Johns Hopkins. Then I came back to be a leader in my country and become the first administrator of the malaria eradication program. There was an investment. I didn't know that Sanait Araya, her father, he's from Eritrea, was my roommate. I discovered it here. Sanait, who's your father? Said, Araya Tsagai. I said, my God, both of us were participants of USAID. I think these are lessons to be learned. I regret it, and 3 presidents today make me very proud. I teach Obamacare, but I also am proud to see that both presidents have agreed that Africa has a priority through PEPFAR, and now comes the president's initiative. I don't think selling arms will take us anywhere. These are selling injections and vaccinating people who have more returns for us. I think I'm now, as a US citizen, I'm look at it differently now. I traveled to Ethiopia, but I regretted 1 year, 73 until 19, when the United States stopped its relationship with Ethiopia. That was catastrophic. We had 2 pandemic malaria, 1958 and now 1968, 78. These are the worst time. That's when the United States was not involved. And I think this is a very good lesson. I'm a US citizen now, but I think I owe it to USAID for going back and forth. And it's good to see that gentlemen and ladies and gentlemen here. I think we have to get engaged in health. Health is politics, politics is health. That's where I learned. Thank you very much.
Thank you so much. So let's see if we could have our panel respond to some of the questions that were raised around lab equipment, maintenance and reagents, health information systems, surveillance, and then also reaching the pastoralist populations. Who'd like to take a crack at it?
Yeah, I'll talk a little bit about the lab. Clearly, there's a need. The part of the NTB strategy is to have 90% of patients with TB having full drug susceptibility testing, which means culture and DST performed. So there's a big gap there for Ethiopia to approach that target. At the same time, the other laboratory tests are also important, particularly with the MDR-TB regimen. The clinics we visited, and this is not unique to Ethiopia, often have a laboratory device that's no longer working. They can't get reagents. And so they're treating a patient with an injectable kanamycin drug for months. This drug can cause renal insufficiency, other side effects, and yet they can't get basic laboratory tests to say the kidneys are okay, you can continue. Or there's liver injury going on here. They have no way to diagnose that. So there's clearly a need for basic laboratory support to be improved as well. I don't know if that addresses your question there. In terms of the record system, one of the USAID projects that we visited, Heal TB, they had developed a very nice electronic medical record system for tracking all the different components of TB outcome, really designed not only to feed information to the national level for reporting purposes, but also to allow the practitioners in the community to look at how they're doing and what their gaps are. And I'll stop there. Thank you.
Okay. I would add, I think the two areas I heard you highlight in terms of laboratory capacity was both, the infrastructure, including the reagents and the ongoing supply and supply chain, but also the human laboratory capacity, the cadres, the multiple cadres, how do you get out there, which is, critical. And I would weave one of the things that we're most, dedicated to within that also through CDC is the idea of quality, right? So quality monitoring systems, EQA, ways that over time the system has sustainable checks and balances to maintain standards of practice. I think useful to highlight one of our huge partners in this is the African Society of Laboratory Medicine, which fortunately is based, I think, in Addis as well. And I think having a network of senior laboratory professionals from around the continent that are both informed by but also dedicated to the strengths and gaps and the innovations within their own countries that can be a resource for helping Ethiopia and other countries tap into longer term both training and capacitation and technical assistance elements for how to improve the supply chain, how to get to laboratory certification, but also I think some of these more complex policy issues of what types of lab cadres do we need going forward other than just the lab cadres we have right now? How do you project into the future? So we look forward to continuing working with ASLM as well as individual countries on being able to continue to build capacity over time. Surveillance and reporting systems in HMIS, certainly we've invested a lot in many of those systems for HIV and TB, and I think as we continue in the global health security, some of the purpose of the emergency operations centers are about how do you not just get that data, but use the data. Which data need to filter up to the top in a more rapid format so that there can be a response. So a lot of the focus also on how do we use the data in new ways. I think for HIV, as the epidemic has changed and shifted based on the successes of Ethiopia, we're also questioning what do we need to know now and how can we learn it? It might not be a typical case report of a more general disease. So we are supporting right now, I think, something called demographic surveillance sites under 6 universities and a burial site event registration in Addis Ababa to try to get into, in this lower level of epidemic, what's happening for mortality now related to HIV and others. Can we figure out where we're missing things? Also, Ethiopia is one of the 13 countries that is in this new round of sort of what's a next generation population-based survey for HIV that's called the Population HIV Impact Assessments that include not just information that will give you a national prevalence estimate, but also enough information that should lend itself to national incidence estimates and subnational estimates surrounding prevalence, being able to look at how people are using services and who's not engaged in services. What is the viral load? What is the resistance pattern amongst people who have detectable viral load? Do they have drug metabolites in their blood so that they're actually on treatment but it's failing? Those kind of next generation answers that are needed in a lower level epidemic that has had a lot of successes to really hone in on what do we need to do next, which wouldn't be captured just in a national sort of case reporting system.
Great. Well, I think lunch is here, so it's about time to wrap up this great panel. But let's thank all our speakers for speaking on this panel today. Before